Hi, everybody. My name is Elaine O'Connor. I'm the medical director of the MaineMOM initiative for the state and also the director of perinatal addiction medicine at Maine Medical Center. I am recording the May 2025 MaineMOM Echo presentation, Implications of Toxicology Testing in Pregnant and Postpartum Women with Substance Use Disorder. So objectives, we're going to understand the downstream effects of performing toxicology testing in pregnant and postpartum women. And we're going to really understand the limitations of toxicology testing as a tool for understanding substance use risk for families. So overview, pregnant patients prescribed medication for opioid use disorder perceive mandatory child welfare reporting at birth to be unjust, stigmatizing, and harmful to the family health. So there's been a lot of conversation within the state of Maine about who should be reported, what should be reported, ongoing legislation to change how it is defined. And to put more in rulemaking rather than legislation, because that is easier to change. But I think it's widely believed that at this point, certainly reporting folks who are on MOUD and stable and have no other possible reasons to report from a abuse or neglect perspective really don't need intervention from the Office of Child and Family Services. So, and we don't want to treat this disease differently than we treat other chronic diseases. And many studies have shown that punitive child welfare reporting policies decrease access to substance use treatment and fail to improve neonatal outcomes. So really clear that best practice is to have patients seek care during pregnancy. But the reality is a lot of women don't seek substance use treatment. They don't seek prenatal care because they're sort of afraid to disclose substance use, afraid to provide evidence of substance use. And the reality is, unfortunately, sometimes treatment during pregnancy does provide evidence of substance use that can sometimes be used against them as it pertains to child welfare issues at birth. So toxicology testing can play a role in child welfare cases, and it can help inform stability in treatment if the test is interpreted correctly. So we know that using toxicology testing for screening for a substance use disorder is not evidence-based best practice, but there is a role for using toxicology testing when someone's in treatment to verify that they're taking their medications, to verify their recovery. But it needs to be used in the right way and it needs to be interpreted correctly. It's crucial to remember that drug test results are just one piece of information in child welfare cases, and a positive result doesn't automatically equate to a child being at risk. I just want to note that due to time, this session should not be considered instructional on how to interpret toxicology. So in other words, we're not talking about the specific test that we order, immunoassay versus confirmation. What does the creatinine of the urine mean? What are oxidants? Different testing matrices like blood and urine and hair. This is really a conversation about interpretation and some of the changes that have happened over time in terms of being able to detect things down to a smaller level, and also how fentanyl in the drug supply has really changed the game. So who's most likely to be tested at birth? Really important. Peripartum toxicology testing is disproportionately performed on non-white, younger, and poorer individuals and their infants, with cannabis use and medical complications prompting testing more often for patients of color than for white non-Hispanic individuals. Clinicians were more likely to order drug tests for Black newborns compared to white newborns, so 7.3% compared to 1.9%, and those of other racial and ethnic groups when there was no obstetric urine drug test performed during the pregnancy, so more likely to just order those tests. Black women and their newborns were 1.5 times more likely to be tested for illicit drugs as non-Black women in a multivariable analysis. However, race was not independently associated with a positive result. So in other words, we're discriminating against a population of folks, patients of color, but the data says they're no more likely to use substances, and we know that. So this is really a discriminatory way to test folks and needs to be really evaluated at all levels of the system. So metabolism in pregnant patients, we know that that changes pretty dramatically. It's certainly an issue for those of us that prescribe medications. People often need, split daily dosing of methadone because their body metabolizes so much faster during pregnancy. So certainly that's not unique to the medications of opiate use disorder. This was a study of 420 patients in an integrated perinatal and SUD treatment program. and found that metabolic ratios, so the ratio of norfentanyl, which is the metabolite, to fentanyl, which is the primary substance in urine, that ratio in pregnant patients were significantly higher than the metabolic ratios of non-pregnant patients, indicating that the rate of conversion of fentanyl to its major metabolite, norfentanyl, was faster in pregnant people. So they're just metabolizing quicker that primary substance fentanyl down into the norfentanyl. The results also showed a large variability in fentanyl pharmacokinetics in pregnant people. So a large standard deviation of average metabolic ratio, and the range is higher than previously reported in non-pregnant patients. So what that tells you is that they're metabolizing quicker as a general rule, but there's a huge standard variation. In other words, there's a lot of variability in how it changes amongst women. So sometimes, it's hard to use it as any kind of measure. So the wide variability and increased rate of transformation to norfentanyl create complications in the interpretation of urine screens for pregnant patients. So because it's metabolized faster, because there's much more variability in how it's metabolized, you really can't use levels in any kind of meaningful way. And I think people should be really cautious about using levels to begin with, in terms of, particularly when people are using levels to interpret whether a patient's taking their medication correctly. That's really not appropriate in most cases. So there's also protracted renal clearance in patients with opiate use disorder. So a study of individuals in a residential treatment program showed that the mean time for fentanyl and norfentanyl clearance was 7.3 and 13.3 days. So in other words, that metabolite stayed in the system for almost 2 weeks. One participant continued to test positive for fentanyl for 19 days and norfentanyl for about 26 days following their last use. So this is not specific to pregnant patients. This is just a study of looking at folks who have OUD, who are exposed to fentanyl in probably relatively large quantities, and how long it can stay in their system. So fentanyl clearance in persons with opiate use disorder is considerably longer than the typical 2 to 4 day clearance of other short-acting opioids. Which likely explains the challenges we see with buprenorphine initiation as well. So we see that metabolite, the norfentanyl, staying in the system for an extended period. We start the buprenorphine when patients are, feeling like they're in withdrawal, and it ends up making their withdrawal worse. So it's just really important to note that this is, fentanyl has really changed the game in a lot of ways, and really the interpretation of drug screens has become even more complicated. So what about the fentanyl clearance during pregnancy? So this was a case series that looked at 3 pregnant women who showed low levels of norfentanyl, so the metabolite, for 294, 126, and 231 days after their last fentanyl use. So this was verified by a patient self-reported abstinence, was supported by consistently negative urine fentanyl levels throughout the collection period, compliant weekly urine drug tests that were otherwise only positive for buprenorphine, and negative fentanyl and norfentanyl in umbilical cord toxicology. So this really highlights that, what you do with a small amount of norfentanyl that's in the system really needs to be interpreted super cautiously. These low levels that we can test down to, 16.3 nanograms per milliliter, is something we couldn't even probably test for 5 to 10 years ago. What does that really mean? It's an infinitesimally small amount of the drug. And so just, we need to make sure that we're making decisions and interpretations that are correct, based on numbers, and other variables. Second case report of pregnant patient found that despite opioid abstinence, the patient's urine was positive for norfentanyl on 10 distinct GCMS urine screens. So that's confirmatory testing, which means it's definitive. The results demonstrated a steady decrease of norfentanyl over the course of 70 days after her last fentanyl usage, far exceeding expected rates of fentanyl clearance. So clearly when folks are using fentanyl and they have an opiate use disorder, we're seeing this very extended clearance. Despite compliance and treatment with MOUD, the presence of norfentanyl in urine has significant consequences on the maternal-child dyad in the postpartum period. Caution should be used when using low levels of norfentanyl to determine an individual's abstinence, as it can lead to further discrimination against women on MOUD. So what I really want to highlight is that toxicology testing interpretation is really a medical procedure. And so you need to make sure you have the right folks assisting with the interpretation of these tests. I mean, I've seen, cases be open for a norfentanyl of 10 that probably was nothing, that, appeared sort of postpartum, no recent use. And we're really clear that fentanyl is probably stored in the fat cells for an extended period of time. And does sort of slowly come out over time in many situations. So these low levels, we need to make sure that we're not, inadvertently discriminating against folks. This is a level of 16.3 is certainly not consistent with like the use of a gram of heroin or fentanyl last night. So just we need to be cautious about that. The epidural containing fentanyl. So this is another common source of confusion. First of all, women don't always know that in fact, they rarely know that their epidural contains fentanyl. They're generally not consulted or consented to that. The other thing is that the medications that are in the epidural are not in the med list per se. So because they're sort of recorded elsewhere, typically, at least in our electronic medical record. So you won't necessarily see fentanyl in the med list, but it will have been in the epidural. And unfortunately, this is just the way it is right now. I've actually had conversations with OB anesthesia about, is there another opioid that we can use that would be less confusing? Because of course, this wasn't an issue when heroin was actually heroin from the poppy plant. But there isn't really another option that works as well. So we're sort of stuck with fentanyl. So one study found that 76.9% of infant urines were positive for fentanyl on LCMS testing. So again, definitive testing following exposure to an epidural containing fentanyl. Maternal urines were all negative for fentanyl prior to the epidural. So a huge percentage of infants tested positive from that fentanyl epidural. A second study found that 29% of neonatal toxicology screens were positive for fentanyl following fentanyl-containing labor analgesia. The positive test results strongly correlated with the cumulative dose and duration of labor analgesia. So they're more likely to test positive, which makes sense the longer they're exposed to the fentanyl in the epidural. The odds of a positive neonatal fentanyl screen increased fourfold for every 5 hours of maternal exposure. So this just makes sense. They're getting exposed to more over a longer period of time. And so they're more likely to test positive. So this, fentanyl for in labor analgesia may lead to positive maternal and neonatal toxicology tests at various times after epidural initiation and cessation, and at different rates depending on the testing method used. Caution should be used in interpreting toxicology test results of individuals who received labor analgesia to avoid false assumptions about non-prescribed use. So what's really, really helpful in these situations, and what I always try to do for my patients, is to make sure that they leave a urine when they get to the hospital to deliver their baby. So I tell patients really clearly, like when you arrive onto the floor, and you're in labor, really ask to leave a urine sort of first thing. Make sure you say, hey, I really want to leave a urine for a drug test first thing, so that this issue can really be taken off the table. And I've definitely seen this happen where there was an assumption that because the baby tested positive for fentanyl, that the mom had used fentanyl. But we were able to look back at the drug screen that she left when she got to the hospital, and that was negative. So that really took that question off the table. Incredibly important. So really important to talk to your patients about this, again, because nobody will say, oh, and by the way, your epidural has fentanyl. So be sure to just leave that urine. I just say, leave a urine before you are given any medications, before you take anything, before you have your epidural, just to take that question right off the table. So targeted reporting and safety of infants. So I think the adoption of a trauma-informed clinical practice guideline requiring identification of specific protective concerns in the setting of prenatal substance exposure led to a large reduction in child welfare reports. So one of the things that states are talking about is like, how do we do this better? How do we not stigmatize everybody who has a history of an opiate use disorder or everybody who's on a medication for an opiate use disorder? How do we really make targeted interventions? Because as you can imagine, if you're trying to screen 500 people, it's really hard to find, the 10 people with, so if OCFS gets a referral of 500 people, it's really hard to find, say, the 10 who have significant issues. Whereas if you're able to use a much more structured, robust clinical practice guideline that can help the medical team kind of tease out whether there are concerns here, a lot easier to find those 20 when you're trying to find them, or 10 when you're trying to find them in 50 versus 500. And so that can be very, very helpful. And there's a variety of these available in the literature. This particular one was done in Massachusetts. And when using this clinical practice guideline, there's no significant changes in custody at discharge or length of stay, suggesting that the guideline did not alter short-term disposition or discharge readiness. So there are ways to do this in a very targeted fashion using a robust clinical practice guideline that is applied consistently. Because again, remember, we're trying to make sure that everybody is treated the same. And only there's also been data looking at what about substance use during pregnancy? Is that indicative of a return to use postpartum? Because historically around breastfeeding and other things, there was sort of all these guidelines that said like, oh, 30 days this or 30 to 90 days that. And in a pretty large study, the authors found that only non-prescribed use, i.e. a positive drug screen at delivery hospitalization, was significantly associated with non-prescribed postpartum use in the first 6 months postpartum. So use within 30 or 90 to 31 days prior to delivery was not associated with postpartum use. So it's even more important to get that urine at delivery hospitalization, again, to try to determine whether there's any substance use prior to coming to the hospital. But really, it's only active use at the time of delivery hospitalization, not anything earlier in pregnancy. So the key points, the faster rate of conversion to norfentanyl combined with the potential for prolonged clearance means that norfentanyl may not be an accurate metric of recent opioid use. So those small numbers, those numbers that kind of appear out of nowhere, that make no sense, really need to be evaluated very carefully. Urine drug test results require medical expertise for active interpretation. What I always say is like, hey, this requires a medical order in the medical record. Like I have to sign off on every test that's done because that's part of the rules. Like nobody else can just sort of order a medical test. It has to be somebody who has the authority to sign off on that. So it really is a medical test, and it's not something that every medical provider knows how to interpret. This is just a very, like with all things. I mean, there's definitely things that I don't know how to interpret that would be a lab test result. So it just makes sense that there's certain things that I'm good at because I see a lot of it. I do thousands a year versus somebody who tests for something very different. And they're an expert in that aspect of things. I mean, people I think most medical providers are at least familiar with the idea that there are these tests available, but specific interpretation really requires advanced training in addiction medicine. And unexpected test results should always be reviewed with a medical professional to explore possible explanations. So if folks are saying, look, this doesn't make sense, I didn't use, I don't know why this test's positive, or I, took this medication before I came in, and that's why I have a positive screen. Really important to have that conversation with patients to get the appropriate clinical guidance that you need. Super important, as I've talked about already, to collect the urine before the epidural. And clearly, misinterpretation of drug test data can lead to harmful consequences. I've seen this firsthand where, there was a report from a hospital that the baby tested positive for fentanyl. That ended up in the preliminary protection order in the DHS case, and that went all the way to court. And because there was nobody who was really looking at it from the medical perspective, the hospital just said, well, this tested positive. And OCFS said, okay, well, it tested positive. And so I think it's kind of unclear in many of these situations, like whose job is it to really figure out whether it represents a return to use. And I think there's an ongoing dialogue about that right now. But urine drug test results alone cannot determine return to substance use and should not be the sole factor in high stakes decisions regarding custody, legal status, or treatment requirements. This is very distressing for me. I had another case a couple weeks ago where I had a patient with a very unusual test result that really wasn't consistent with a return to use and didn't really make sense. We kind of teased out some of the reasons behind that. And ultimately, there was really not a return to use. It made no sense. We had a negative test from the day before. We had a small amount on the day that she tested positive. And then, a day later, we had nothing in it. So it really made no sense. It was not consistent with a return to use. But that took a lot of advocacy, and she was about to lose her housing. So this is a high stakes thing, and I think in part it's because it's probably the only objective way to measure substance use. I mean, there's not a lot of other tools that can be used, but I think it's just really important to make sure you get the clinical advice that you need. And if child welfare reporting is redefined based on expert identified protective concerns rather than sort of categorical mandates. So rather than just saying, oh, if you're on MOUD, you need to be reported, we should really be using a tool that identifies whether there's a risk of future harm or current safety risks. The benefits certainly could include conservation of limited state resources, a reduction in family surveillance, and mitigation of stigma. So when I think about this population is so targeted in the hospital setting just because of their history of a substance use disorder. So, as it pertains right now, if you're on a medication for an opiate use disorder, you get an OCFS notification, which is different from a report. but patients don't see it that way. They don't, it seems like one and the same. And so it's really important to um, really further refine how we're doing this so that we can best identify who might be at risk. I think I provided a couple pages of references here. Definitely review those. And if you have any questions, please reach out. I'm happy to help in any way that I can. Thank you.